Good evening, everyone, and welcome to this first ever live webinar with testhim. We're coming live from our testhim studio, slightly different studio, but welcome. Nice to have you all here, and a huge thank you to Jonathan Ramsay for joining us tonight after a very busy day in clinic, and you've made the effort to come and join us tonight, so thank you very much for coming. You will notice that we're actually missing one member of the testhim team. Toby Trice is here, but only remotely. So Toby, hopefully you can hear us, and hopefully everyone can hear you. You've been too busy crashing cars, been advised not to drive at night at the moment, so we're at least pleased you're here remotely.
Oh, thanks, Ian. Sorry, I'm not there. And Jonathan, thank you so much for joining us live tonight. Of course, the crash has hindered me somewhat, but I'm on a good recovery. So anyway, let's jump into to our live this evening. First off, testing 1.
Testing 2.
Testing 3.
And a guest who is very, very happy to be here. Thank you all for the invitation.
Oh, wonderful.
Great stuff.
You're supposed to say testing 4 at that point.
Yeah, you could say testing 4.
Well, I could. I didn't know whether I could be adopted.
Oh.
I
think you've already been adopted, Jonathan.
Yeah, absolutely.
Absolutely.
But yeah, tonight we're going to be chatting all things DNA fragmentation. We are going to get the insights from Jonathan about why this is so important, why men should be getting tested, kind of try and dispel some of the myths and bits and bobs there. And we will try and take some questions as well. So if you've got any questions, do pop them in the chat box. I'm going to be keeping an eye on the chat box throughout the chat. We'll do our best to get them all in if they are there, and we'll go from there. So, Jonathan, how would you explain DNA fragmentation in the kind of simplest terms so that people can kind of understand it?
Well, thank you. Because it's only the simple terms, really, that even the doctors understand. And amongst those doctors, myself included, because it's important not to make this too complicated, because when you boil it down, the matter of fertility is really about the DNA, the little tiny package in the sperm head, and the DNA in the egg, another little tiny microscopic package. And if one thinks about this, this is quite extraordinary, because 50% of the instructions for a human being are in this little spot, this granule of protein, very tightly bound, like a ticker tape that's bound into a Catherine wheel. Now, of course, that Catherine wheel might unravel, and little bits of protein might come off the end. Now, this is happening throughout our body. DNA is being split, broken, and repaired. So, spermatogenesis, the business of making sperm, each of those sperm with this little tiny instruction in it. It's not surprising that as sperm are being made so rapidly, so many of them, that some of them would be made impaired or damaged, and some of that DNA might fragment. So the fact that some of our DNA is fragmenting is not necessarily abnormal. But like so many things in life, this is about the proportion or the degree of fragmentation, which at a certain point becomes critical. And that critical point differs according to the man's circumstances and indeed according to his partner's circumstances. Because a very fertile young egg has the ability to repair DNA, either damaged for some extraneous reason, or particularly when it enters the egg as part of a sperm, either naturally conceived, a natural entry of the sperm, or an unnatural entry as in injection of that sperm, ICSI. So it's all about, like so many things, degree of damage and the specific circumstances of the two people who may be suffering some damage.
Yeah. And And that DNA damage, like I say, it's a degree of. Why does it matter so much? I mean, it's the blueprint of life, right? So those blueprints have got to match up. So why does it matter so much in terms of that kind of that embryo or that egg being fertilized, the embryo developing, and then kind of things going from there?
Well, of course, the scientific word is embryogenesis, the genesis or the derivation of a new entity, which is an embryo from the two sources of DNA. And if 50% of the DNA is not carrying the right instructions, then of course either no embryo or blastocyst, no 5-day embryo is created, or that blastocyst might not implant because it's not good enough, or indeed that blastocyst, once an embryo, might miscarry early on in the pregnancy. So if you like, the body does have fail-safe mechanisms to ensure that genetic information in the DNA, which may have been misconstrued, mismade, or misinterpreted, doesn't result in an abnormal embryo that then develops into a baby. So these are about the fail-safe mechanisms. So once again, one way of looking at DNA fragmentation is that it is part of the body's defense,
Okay.
rather than saying that this is always something that is part of an illness or a big problem. So one's got to temper this. This is a very, very subtle process which we don't properly understand.
Yeah.
We're really just scratching at the surface of this.
Yeah, and I like the point you make about that. It's about this kind of spectrum, isn't it? Of you could have moderate DNA fragmentation going on in the sperm, but if it's a young egg, that's probably or possibly not a problem. But you switch that around the other way, to an older egg, that's a significant part of it. And I think time is such an important part of the equation here, isn't it? In terms of perhaps measuring DNA fragmentation, responding to that result and what you do with that patient and how you kind of coach or support them. But you've got to take into account the female age as well.
And the story, because you're so right there, Ian. We often see increased DNA fragmentation in the context of a couple who have had a natural conception relatively easily. And they think, oh good, everything's fine. And they start trying for the second baby, and when it doesn't happen, they think, oh, it must be fine because we have a little boy or a little girl, and that happened within 3 or 4 months. And so that situation, as we know, gets the label, the most unsatisfactory label of unexplained infertility. Now that is often explained by increased levels of DNA fragmentation, which, as you so rightly say, didn't matter 3 years ago when their little boy or little girl was conceived. But with the passage of time, it does. It explains the unexplained. And quite often, because there's no fundamental problem with fertility, we find an explanation for the unexplained, which is the DNA fragmentation, which quite commonly, for example, is a collection of veins warming the testicles, known as a varicocele. So that's a very typical story.
Yeah. I was going to ask, what are the kind of most common, what are the causes of DNA fragmentation? Because there's so many elements to this, and obviously age is one of them as well. So actually, men, pay attention to your age because it is a factor. But there are a lot of other factors, aren't there, in terms of DNA fragmentation that could be impacting?
Well, there are, and I think that the simplest and possibly the most important way to look at this is that our DNA, I say our, particularly my, due to my advancing years, is fragmenting all the time. And age is relevant because, as we know, DNA damage, not just in sperm, which is a particular case, but DNA damage in the skin, DNA damage in the lungs, throughout the body, happens with age, and that's why we develop tumours.
Mm.
So age is relevant, but then if we extend that, we all know that certain behaviours cause DNA damage, and that's why smoking causes lung cancer. So it would be very, very odd if smoking was not particularly deleterious to the DNA in the sperm.
Mm-hmm.
Yep.
So an awful lot follows, actually, from first principles and common sense. One of the problems with selling DNA fragmentation tests is it sounds so scientific as soon as you start talking about DNA, single strands, double strands. You get into the realms of science, and people think this isn't for me.
Mm.
I'll just have some IVF, that's much easier.
Yeah.
And I think the biggest issue is that it's not just a number. It may provide a risk, but you can't really use it in isolation, just like many other tests are really, important to look as part of a larger consideration of the man, the couple, and what else is going on in their lives. So I don't know if you've got any comments on what else should we be looking at with, an elevated DNA fragmentation.
Absolutely.
Yeah.
So I think this is the kernel of the issue. Once one's got away from the general lifestyle things, which are really important, the next thing which we touched upon is abnormal heating in the scrotum and around the testicles. Because if one reflects upon this, why ever is it, they're all men in this room, so I can say this with impunity, why is it that men, we, wear our testicles inconveniently in a scrotum, in a sac outside our body? Well, part of the reason, at least, is because they enjoy 3 or 4 degrees centigrade below core. Now, that's quite cool.
Mm.
If we think of a hot bath, maybe 38, that feels warm, it warms the skin and dilates the blood vessels. But if we take 4 degrees off that, it's distinctly tepid.
Mm-hmm.
And that's what the testicles enjoy. So if you then wrap them up in some dilated veins, a bit like the varicose veins you might see on the back of a leg,
Yep.
these are quite big and they're full of warm blood. So up the temperature goes to core. And then the poor man, thinking he needs to be fitter, gets his lycra on and starts pedaling for a couple of hours a day. He loses weight, yes, but of course he's heating his testicles, and then as a reward he comes home and has a hot bath. Now if he's also got veins around his scrotum, then his testicles are not just increased in temperature when he's exercising in the lycra or in the hot bath, but actually all the time.
Yeah.
Mm.
And this is a very significant cause of raising that fragmentation enough to cause a bit of a problem, as Mike just said, particularly as time passes or other things have occurred.
And we're not just talking, just one result. We often see other parameters of the semen analysis that are also impaired. So is it right that there is a direct correlation between a semen analysis and a DNA fragmentation test or an oxidative stress test?
Well,
Or can they be completely independent?
I think they can be independent. What we like to find, what scientists like to find, what men like to find is a nice linear relationship. A linear relationship, for example, between the parameters of a semen analysis, the motility, the numbers, the morphology, and the outcome of an IVF cycle. But of course, we've known for 30, 40 years that that is not true. If it were true, then of course you could predict the outcome of an IVF cycle on the basis of the semen analysis. But you can't. So the semen analysis is not very helpful. It's often indicative of a problem, but there isn't a relationship between it and IVF ICSI outcome. So is there a direct relationship, which is at the back of Mike's question, between DNA fragmentation numbers and IVF or ICSI outcome. Almost impossible to prove that. It's very likely, but to do a prospective trial, looking to the future to see whether that was the case, is very tricky.
Yep.
But what we can say is that there does seem to be an overlap, particularly between sperm quality as measured by morphology and DNA fragmentation. But that overlap is not complete. It's like a Venn diagram. It's like two circles which are intercutting, overlapping.
Interesting.
Because a lot of couples end up hearing, well, your semen analysis is fine. There's nothing else to worry about. Let's crack on with fertility treatment if you're not trying to conceive. It seems very hard for couples to kind of not understand. I don't think they're being given the right information that a semen analysis on its own may not be the best test to have done, or it's a good first test, but it's not really showing anything about that sperm's ability to fertilise an egg.
No, it isn't, because it may be outside the overlap. So you think of the Venn diagram, the two circles, and this leaves a big part of each circle actually outside that overlap area. So just as you say, exactly right, Ian, it can be that the semen analysis looks quite normal, but actually the DNA package, the important payload of the sperm, isn't normal.
Because that's all sperm's there for, isn't it? It's just to carry that DNA and put it inside the egg. That's
right.
its only job.
It's a sperm vehicle,
Yeah.
a DNA vehicle.
Yeah.
It's a DPD delivery van
It is.
or other ones. But I think we should just bring Toby in here because
bring Toby in because
he's-
varicocele is something that you might be familiar with, Toby.
a normal semen analysis, a varicocele, and then what happened?
Yeah, exactly. And it's all too interesting, actually. But just hearing you talk then, Jonathan, about the fact that what looks like a relatively normal semen analysis could actually mean that there might be further issues. And that was very much my story. I don't know if you can remember when we first met, and we walked through all my kind of embryos, and the fact that they were kind of collapsing through IVF. But my semen analysis was actually pretty normal, despite a little bit of lower morphology. But actually, it was quite apparent that I had quite high levels of DNA fragmentation. So I found that really, really interesting. Worrying at the time, because obviously I was 6 years into my fertility treatment at that point in time. But actually, we had a potential cause for that. And obviously, you've mentioned varicocele in this, but after a physical examination with you, Jonathan, it was very apparent that I did have varicoceles present. Little did I know how bad they were at the time. Not until I eventually had the embolization done and realised just how severe they were. But it really blew my mind, actually, just having that kind of simple analysis of looking at the DNA fragmentation, and what felt like quite a scary word at the time actually was nothing to worry about, because it gave us information and we had a potential root cause for that. And ultimately then we then moved on and had an improvement after having the embolization done. So it still blows my mind. I mean, DNA itself is quite an incredible piece of our body, our thing, and the fact that the egg can kind of make repairs. But in our situation, I believe that my partner's egg quality, wasn't able to repair the DNA of our sperm, so therefore I had to have that treatment to improve it. And obviously we had positive news at the end. We fell pregnant naturally three months after that surgery, which still to this day blows my mind. But it just shows how important it is to get those kind of tests done really, really early, and see someone like yourself that can look at a physical examination and further look at what is causing a guy to be subfertile. It proved to me just the huge importance that is.
I think there's the point within that a lot of... I remember, Toby said so many times when he got his DNA frag results from me, so somebody he knew, and we had a relationship and we're able to talk, with no constraints of time or whatever, and I was able to support him through those results, but he still found it very difficult to get those results. Is that's your result. There are options after that, and actually it's not a finite thing. I mean, there are genetic causes of DNA fragmentation, I'm right in saying, aren't there, that maybe you can't rectify, but there are a lot of causes that are entirely fixable, and that men perhaps shouldn't be scared of getting this test done, because you can potentially fix it.
I think you make both of you make a very important point about the scariness of both abnormal sperm morphology, the shape of the sperm being odd and peculiar, and the Latin word for that, of course, is teratozoospermia, and the terato bit, the prefix in Greek, means a monster.
Mm-hmm.
And so to be told that your sperm are of an odd shape and you haven't had a baby, or worse, you've had miscarriages, a lot of men think, well, this is it. This is the end. Because not only can I not have a baby, but the ones that I am going to have will be abnormal, which is absolutely not the case. But because of that, being humans and being men, again, we're all men in the room, and not very keen on visiting doctors, we internalize this bit of frightening knowledge, and we actually are reluctant to have any more tests, reluctant to have the DNA fragmentation. And when a man is then told, without the support of Ian or somebody else, that his DNA, the essence of life in his sperm, is fragmented, broken, then this is devastating. It's a terrible diagnosis coming out of the blue.
Yep.
And so I think it's very important to understand that this fragmentation, which is where we started, is happening to a certain extent all the time. And it's merely a matter of degree. This is an extension of a normal physiological process, and it is our job to try to identify, as with the varicocele, as with the lifestyle, and as with the other things that we can come on to, ways to try to improve it. Not to make it perfect. You'll never make your DNA perfect, because it's in its nature to gradually deteriorate.
That's quite reassuring. I quite like that reassurance that this is happening all the time. It is a degree of damage, and it's what else you're doing that could be adding to that damage, isn't it? That you can then change, whether that's lifestyle and diet or it is varicocele. Another common one that comes up is infection. How much does that potentially impact DNA in sperm?
Sure. So we actually know, I know, and there's a difference between know and think, know very little about this. Now, why do we know very little about this? Well, the first reason that people don't know enough in medicine is because they haven't looked enough. The second reason is that their minds are closed to a new proposition. And the trouble with the issue of infection is that what we think describes infection or is a sign of infection is a bunch of symptoms. It's pain in the urinary system. It's difficulty passing urine. It might be a fever. It might be a terrible illness. And as we hear for the poor old NHS, it may be sepsis. So infection is associated in our minds, certainly, with an altered state, a physically altered state. But what we're talking about when we're looking for infections, i.e. the presence of germs in a sperm specimen, is merely the presence of those germs and an imbalance of the germs that are usually there. So it's not really an infection. Now, if at one end of the spectrum you actually have a single germ that has overgrown all the others, and there are symptoms because this is urinary tract infection, then it would be typical, and indeed is the case, that inflammatory process with the white cells that rush there to try and eat the germs, phagocytosis is the technical term, all this inflammation, not surprisingly, buffets the poor sperm. They begin to move less well, and their DNA may be damaged because the membrane that protects the head of the sperm is being destroyed by all those peroxidases and chemicals that are coming out of those white cells that have rushed to the prostate or the urethra in the penis to deal with this true infection. Right, so we can all understand that. But if you look at 100 chaps who've got impaired fragmentation, it may be that 1 or 2 of them have had an infection with symptoms in the past, but they don't have anything like that now. And so when somebody like me, during this webinar, talks about infection, then other doctors will say, oh, this is all complete nonsense. These men who've got poor quality sperm, of course they haven't got an infection. You know, I've been in practice for years and years, and I know, and everything else. Well, what we're now talking about, what you're talking about, is a much lesser form of having symptoms. It's having an imbalance of the germs that are there anyway. Now, as soon as we talk about an imbalance, then we're talking about probably 100 candidate organisms. We're talking about what is called a microbiome. And the word that is applied to an imbalance of these maybe 100 organisms is a dysbiosis. That is, those biological agents are out of balance, that a group of them, a cluster of them, is taking over. Now, those organisms might be causing a little bit of inflammation, which against a background of possibly getting a bit older, possibly having a bit of a varicocele, a whole load of other things, is enough to tip that DNA fragmentation into a critical category. So I think that this is an important aspect of fertility, but I don't know it.
You're right.
And I think it'll be very difficult to prove it.
Yeah. So we need more research, really, in looking at and understanding the balance of the microbiome in seminal plasma, for example.
Exactly. And comparing that with the microbiome that we find easier to accept in the vagina.
Yep.
And gynecologists are beginning to get to grips with this. It's a really difficult subject because if you look at the organisms in the vagina, naturally occurring in the vagina, there's a racial variation, there's a variation according to the time of the menstrual cycle, and of course there are more commonly symptoms. When we do know that something's going on, but that something is often treated with a blunderbuss, with broad spectrum antibiotics, and what do? They further imbalance the microbiome.
The normal microbiome.
So this is tricky. But if you ask me what I think this is an area where we will be developing much clearer policies, and where probably we will understand the value of probiotics and the possible danger of antibiotics.
Blimey, we got quite deep and technical.
We did. You already asked a question about infection.
Most
people think about STIs.
You provoked this.
It's all my fault.
You got me going.
Okay. Well, I'll tell you what, let's bring it back to something really simple and meaningful for patients that hopefully, watching this, listening to this. When would a couple begin to question or suspect DNA fragmentation is at play? They've been trying for a year and a half, 2 years. What would be kind of the little alarm bells that say, oh, actually, maybe we should look into this? I mean, obviously, we believe it should be looked into right from the off anyway, but...
I think it's the whole issue of unexplained infertility. So it's the young couple, it's the chap with a normal semen analysis or near normal, when really, particularly with the female partner's age of early 30s, late 20s, then there must be something wrong here. And therefore, if the semen analysis is normal or near normal, it's those cases where we should take it a bit further and look at the payload of those sperm and not just, as we were talking about, the vehicles.
But we're also looking potentially at recurrent miscarriage, IVF failure, repeating IVF failure?
So the next stage, beyond just not getting pregnant, so primary subfertility unexplained, would be recurrent pregnancy loss, so miscarriages, particularly early miscarriages, and particularly again when the conceptions are happening fairly easily. So we know the delivery system must be all right, and we suspect that sperm numbers and motility are all right because the vehicles are getting to the right place. But then something else is going wrong. And my colleagues in gynecology will call this embryogenesis, which we mentioned to begin with.
Yep.
And they will investigate women very thoroughly to see if there's a reason for a failure of implantation. But of course it might be that the manufacture of the embryo is not robust enough itself. And so this is a relatively new concept, relatively new, not accepted by everybody.
Yeah, they talk about receptivity of the embryo to implant, and if there is not the same, receptivity, i.e., the right chemical structure, the embryo, just doesn't know where to go, and therefore will wither away and die, even if those are implanted. So, yeah, it's an interesting, topic really, is whether the right embryo has got the right mix to send the right signals to the womb to say, come and take me and look after me. I think that's a really interesting part of it for miscarriage in particular.
Well, I think you're absolutely right, Mike. And I think that for a long time, we, as doctors, that's my lot, my tribe, have regarded the business of having children as being purely female. So that it's about eggs, yes, it's about age, it's about the anatomy of the genital tract, and it's about the receptivity of the lining of the womb, the endometrium as it's called. But you've only got to open your eyes a little bit to think that why isn't 50% of this problem the sperm? And once you're thinking like that, then of course the DNA quality of the sperm and all the things that might affect that suddenly take on a new importance. But to go from what, the collected thoughts of a man like me obsessed with DNA fragmentation, to knowing that these things are fixable is quite a big step from thinking to knowing.
Yeah.
A lot of couples may have had a test. They may have been told they've got high DNA fragmentation, and they're often advised to them just to have ICSI. I think that's sometimes held up as a solution for high DNA fragmentation. What are your kind of thoughts on that?
Well, worse than a solution, it's held up as a treatment. It certainly isn't a treatment. It might just be a treatment for the infertile or subfertile state. And with any good fortune, 35% of the time, it may indeed be the solution. The problem arises when it isn't. And often it isn't when the DNA fragmentation is bad and hasn't been addressed. Now, I think there are two approaches to this, and it very much depends upon the situation with the couple. If time is short and pressing, and the history is long, particularly if there have been failed cycles before, then I think we really do need to know about this, because if we're going to have another cycle, the same thing is going to happen again. At the other end of the spectrum, when age is on the couple's side, you could take the view that a better biological test of those eggs and those sperm in this particular couple is to do a cycle of ICSI. Because after all, with a younger woman it may well work, and if it works, you could say problem, or at least the problem of the first child, solved. And you will get more information about to what extent in that couple those sperm are indeed damaged, and the significance of the fragmentation compared with the eggs. Because if we get some nice blastocysts, the right number of blastocysts, that's 5-day embryos, then we're beginning to think perhaps this sperm isn't as bad as that. So there is a case, and I wouldn't say every couple who've got a year's infertility have to have fragmentation. I think if they've got a very bad history and we're getting towards the end, so we may have one more cycle in us, then I think it behoves people to know as much as they possibly can about sperm and indeed eggs and indeed the endometrium, the uterus. At the other end, then you can make a case for doing a cycle first, a well-conducted cycle, and see what happens. If you ask me what I would do, well, of course, being obsessed with DNA fragmentation, I would do it when there's a sniff of trouble, particularly as we've discussed when the semen analysis is apparently normal. This is unexplained.
Yeah, I mean, because I've spoken to so many couples that are at that kind of last kind of hurdle, you know, the woman's maybe 40, 41, and they're only just learning about DNA fragmentation, and they're saying, should we get tested, and, you know, is it worth doing? And of course, you then hit that time barrier of, okay, we do the DNA frag test, then we want to try and find out what the cause is if you've got high DNA fragmentation. And if it's a varicocele, then you need to have that repaired, and that's going to take time. You end up with this difficult situation of, okay, well, we've tested, we found a problem, but we don't feel like we've got the time. Which is why, you know, perhaps you're saying, well, when they're younger, just test all the guys, you know exactly what you're dealing with, and you've got time to repair, you know, whatever's going wrong.
Yeah. And I think, of course, I agree with an interventional approach where this is feasible and where it is affordable. But I also am well aware that the three of us in this room, and Toby too, because you run the focus groups and the support groups, we have a very skewed view, firstly, of the number of men with abnormal fragmentation, and perhaps more importantly, the awful effect of this in the people we see.
Yeah.
But of course, like Donald Rumsfeld, we don't know what we don't see. We don't know what we don't know. And there'll be quite a lot of people whose DNA fragmentation has been repaired, who have succeeded with a cycle of ICSI, just one cycle of ICSI.
Yep.
Well conducted, good quality eggs, good embryologist, plenty of eggs, and it works. But we don't see those people because they're happy.
Yeah. I think this is, you know, a really important point, really. I mean, I know the people that I interact with are mainly clinicians. We see patients periodically through the year, and through the support groups and focus groups that we've done, we know that there is a massive, understanding loss, really, that is not explained very well, certainly at primary care level. Not a fault of general practitioners, because they are general practitioners, they're not fertility specialists. But also, in clinics as well, they may not necessarily, men may not get all the information that they may wish to receive in order to make an informed, decision about their, path, their journey, and so forth. So I think the opportunity of having more advanced andrology tests and knowing what they are and where they're particularly useful is really, really important. And I think that this is one of the areas that we need to think about is how do we get this information out to more men who are, and couples that are trying to conceive. We see the people that are most affected by primary or secondary infertility, but how do we get out there to be more informative about those couples that may not present as easily as those that are, ending up in a fertility clinic?
Well, Mike, I think we do precisely this. I think people like me, the mainstream doctors have to be a little bit shameless. I reflected after the Channel 4 program that probably 40 minutes of discussion about male fertility on Channel 4 did more for the cause and the education than 40 years of my clinical practice and writing learned papers and standing on my hind legs and trying to create evidence out of data, which is what happens in fertility. And you hear, I hear, we all hear, the evidence says. Well, there's not much evidence. There is a lot of data, but real evidence, it's tricky, slippery stuff, evidence.
And as you've alluded to before in our previous podcast with you, trying to do these studies and get this evidence and hard data is really, really hard, because you can't really do a randomized control trial with people. You're ultimately rolling the dice of a research study for people that are trying to start a family, and you just can't do that, can you?
You can't do that. No. And if you try to do that, actually you will be entering almost inevitably bias, because you will be losing people who just won't do that. So the people who are willing to have a treatment or no treatment on the spin of a coin, they're self-selecting.
Yeah, of course.
It's really difficult.
Yeah, it's really
I'm very aware of your time, Jonathan, because we're now at 7:45. I think we've got some questions have come in. I think it'd be really nice to try and answer people's questions. Toby, have you got access to the questions there? Because maybe you could be the question master.
No, I could be question master. That'll give me a job to do, won't it, tonight?
Yeah,
really good.
We've got a heap of questions actually. It's been really nice to see the engagement in our live chat this evening. The first one would be, would you recommend having DNA fragmentation redone once you've seen improvements in other elements of semen analysis? So initial frag was 25% with a count of 9 million. The count is now measuring around 23 million. Would you recommend having another DNA frag test done?
Yes, I would, because I think that the fragmentation test may well determine, better than the semen analysis results, the outcome of whatever is going to happen, whether it be natural conception or another cycle of assisted reproduction. And as we've said, although there is an overlap, and it is likely that that improvement will be reflected by a DNA fragmentation improvement, it may not be. It's likely that it is, but the only reason not to do the DNA fragmentation again would be to save a bit of money. So I would tend to use the same marker if we're using DNA fragmentation as a marker of subfertility. Let's remeasure it to make sure we've actually made a difference to that parameter.
Yeah, it'd also be interesting to know exactly kind of what's been done in that time frame as well, isn't it? Because obviously the count's gone up, which is great. But it'll be good to see the DNA side of it, so that based on what they've done, they'll get a true picture of what that outcome has led to, right?
Absolutely, Toby.
So the second question we've got is, we have our first appointment at the fertility clinic next week. Husband has 1% morphology. All my tests so far have been normal. Would you recommend trying IUI before ICSI? And there's an addition to that question, is that they've had 2 miscarriages this year, both around 6 weeks. So wondering what recommendations and what the next steps might be.
I would have a very thorough and in-depth discussion with the clinic about the possibility of doing a DNA fragmentation test. Of course, it's very difficult because one doesn't know the full circumstances, but if it comes to assisted reproduction, then under those circumstances, ICSI would be favoured by most clinics, but certainly that sort of history, I think, would encourage me to encourage the clinic to do a DNA fragmentation test.
Would you also suggest a thorough examination, testicular examination?
Well, of course, I would, Mike.
Would the clinician recommend seeing a clinician?
Well, the clinician would recommend seeing another clinician who doesn't faint at the thought of examining a man's scrotum. Because it can be very easy to ignore the elephant in the room, quite literally. As happened with you, Toby.
That's it. I mean, this conversation tonight is making me really reflect on our journey, because we had 2 rounds of IVF that were ICSI, that both failed, and we had all of the heartache and the trauma that kind of went from that. And we can always look at the data and the research and the benefit for the outcome, i.e. a live birth, that these things are really important. But actually, I think what we always have to remember is that there's huge emotional stress and trauma that goes with any form of baby loss, at least pregnancy loss, or failed IVF or ICSI rounds. And it's really, really difficult for a couple, isn't it? And looking back at kind of our journey, I just wish I had these tests done sooner, or knew about them right from the get-go, because I did the guy thing of putting my head in the sand and thinking, well, my semen analysis is all right, I don't need to worry about me, I'm okay. And my poor partner went through all what she went through and all her test investigations and stimulations and the IVF rounds, etc. And yet that whole time I had a severe problem which is causing our issue. And having this information now is a little bit frustrating for me, because I wish I'd have had it done sooner. But actually that's exactly why we're on this mission, isn't it? Is to try and make people aware that these things are available, so that one can get a better picture of their fertility potential, and potentially prevent miscarriage loss, pregnancy loss, and obviously the emotional traumas that kind of come with that.
My advice to a couple faced with their first appointment in that story is to talk round the issues. So, being a doctor myself, I know we're sensitive, tender creatures, and we don't like being told what to do. We don't like patients who seem to know better, who argue. Now, this is not an argument for diminishing patient power, but there are approaches which are more likely to work. And so if you want to get something out of a shopkeeper, basically talk around the products that he's selling, and see if you can therefore access this in a reasonable way without causing a conflict, the end of which is for the doctors to say, no, we're not going to do that, it's not relevant, it won't make a difference, and then that diminishes even the inquiry. And one is a little bit frightened to go back and revisit it, because after all, it's the clinic who are going to do the cycle. So it's
a fine balance, isn't it,
a fine
really?
balance of how to approach it. But if you're asking me the question, should this man have a DNA fragmentation, from my perspective, the answer is yes, of course. No further discussion.
Any other questions, Toby?
Yeah, of course. Yeah. So the next one I've got is my husband has excellent count and motility, but not state the numbers of those, but 0% normal morphology, all of which are tapered heads. And what are our options for conceiving, or any suggestions to improve our situation?
Well, this is certainly somebody who should have thorough investigations to see whether there are any options for improvement, or whether it happens to be that this form of abnormal morphology is something that is going to be very difficult to alter. So this is precisely the sort of case where I would be doing a full suite of investigations. And I'd certainly be doing more than one semen analysis, because you want to make sure that a serious morphological abnormality is not something that has been misinterpreted or may even be transient.
Okay.
So full suite
so
of
the next
tests.
one is
Sorry, Toby. Yeah, go for it.
sorry, Michael.
No, just a full suite of tests on that one, I think.
Yeah.
So
Yeah, really important.
yeah, Go for it. What's the next one that you're going to say?
The next one I've got is, can low testosterone cause DNA fragmentation?
So it can be part of the picture, certainly. A strong association, because of course it may well be that an underperforming testicle, which has two functions, one making sperm and the other making testosterone, is at the same time making low numbers of less than adequate sperm. So there is certainly an association, and there may also be a mild causal relationship as well, because the testosterone is being secreted into the very place where the sperm are also deposited on the first stage of their journey. And so they need a bit of testosterone locally to go to finishing school. The concentration of testosterone in the testicle is 30 times higher than in the blood. So that tells you how much we need, or our sperm need, testosterone.
Toby looks like he's still computing that.
He's still computing that one. So just
That was
following
funny.
on from the question, I suppose, is it important to check blood hormone profile alongside semen analysis and other tests that you would recommend?
I think when spermatogenesis is absolutely okay, when we're looking at a good count, we're looking at 100 million plus and 50% motility, it's very unusual under those circumstances to have a low testosterone, unless the man is doing something to cause that. So it's certainly not every man, but once one gets into low numbers, then the answer is absolutely. I would always do a full hormonal profile.
Excellent.
And then Quizmaster on Zoom.
So we've got 3 or 4 more questions, if that's okay.
Yeah.
The next one I've got is, would you recommend undertaking additional male fertility test after a failed IVF cycle? First fresh transfer, top grade embryo. I think we've kind of answered this, Jonathan, actually.
I think we have. I mean, I think that of course question depends very much on extra details. So you have to know how many eggs retrieved,
Age
how
of the
many
woman.
how many were mature, how many fertilized, and how many made it to 5 days. So there's quite a lot, as we were talking earlier, of extra biological data that comes from every aspect of that cycle. So it may be that is the right course of action, and often it would be if that result is in any way unexpected. But of course, if there were only 2 or 3 eggs, then this overrides probably the influence of the sperm. And as Mike mentioned, the ages of the couple are also important.
Yeah, there's lots of extra variables when you kind of need more information there, isn't it? But but hopefully that answers your question. Who's put that in? So does ICSI guarantee using sperm with lower frag? I had a miscarriage at 6 weeks. Suspected cause is a high frag on the semen, and both rounds of IVF we've had poor blastocysts, all dying off after day 3. Crikey, this sounds like my story.
Yeah, don't just.
Yeah, that's quite
Yes.
spookily on Halloween. That's very similar.
I think you can probably answer that, Toby. I
Yeah,
expect
probably.
yes. Yeah.
My advice would be to see someone like you, Jonathan, and get a full picture, because our journey was pretty much identical to that. We had blastocysts that were dying off after sort of day 3 to day 4. The 2 embryos that we did have transferred were kind of felt like hit and hopes. They weren't that high grade, and obviously we lost both of those very, very early on, which is obviously very, very devastating. So ICSI doesn't actually guarantee using the sperm with lower frag, because ultimately the embryologist, correct me if I'm wrong, Jonathan, that they can't see the DNA, right? They're only looking for the best looking morphological sort of sperm head, but they can't actually see what the DNA is inside like that. So having a DNA frag test builds a better picture, because that actually is something that is then measurable of how much fragmentation there is kind of present in the sperm and the semen itself.
Entirely agreed. Embryologists do their best. It's a skill set that requires craft. Some are better than others, but in the end they can't see the DNA package. And often in the end, they just have to work with the material they've got.
That's right.
I did actually see a paper, it only came out a couple of weeks ago, that looked at DNA fragmentation. Couples going through ICSI treatment had DNA fragmentation test on that actual sperm for that cycle. And they found that there was a higher percentage of aneuploid embryos when the man had higher DNA fragmentation, even though they were using ICSI. So what that's saying is that those embryos aren't developing well. They're not embryos that are necessarily going to implant and go on to make a healthy baby. And I've always sort of said it's a bit like trying to pick a healthy apple out of a barrel of apples where you've got a lot of rotten apples. And ICSI is in effect kind of doing, there are ways of filtering and cleaning the sperm, but you're potentially, if you've got high DNA frag, you're still picking from a bad bunch.
Correct. Absolutely right.
So we've got another question about the interpretation of DNA frag test results, the relevance of average fragmentation, healthy and unhealthy sperm thresholds. I think that's probably quite a difficult one to talk about on the live chat, but I believe that we're going to be posting out some of this information very, very soon. So for that question, I would say keep your eyes very, very close on our website, because we're going to be doing as much as we can to make all of this information as clear as possible, because obviously DNA fragmentation is quite a complex thing, and we're here to try and simplify that the best as possible. I don't know if you want to add to that, Ian, at all.
I think that's referring to a specific test and the results that come that are quite confusing, perhaps, for patients to interpret. Do you think, Jonathan?
Quite possibly.
No. Well, I think unless you have a very significant understanding of what this means, then the results from all tests can be confusing. And when one compares one test to another test, not only are the numbers different, the thresholds are different, but also the difference between an index and an average. So even my O-level maths tells me that that's quite a big difference. I understand how patients can be very confused about this. What really matters, though, is the proportion of the sperm, whether it's an average or an index, that are of good quality. Mm-hmm. That's really, I think, the most important issue. Followed, if you're doing a test that looks at bad quality sperm, on the proportion that are bad. Mm-hmm. But of course, an index actually blends those two things together. Yeah. So I get it. It is confusing, but I hope, because of what testhim is doing and other ways of doing fragmentation tests that are becoming available, that we'll be able to explain those differences and make it a little bit more understandable.
Yeah, I think that's exactly the point, really, and what we're trying to achieve is to, really demystify some of these tests that are out there, and what do they mean, and, what does it mean for those individuals. So loads and loads of really good information is on our website, and what we're trying to do in these types of podcasts.
I think the other thing with that is actually make sure you've got a clinician that you're speaking to who can interpret those results and then guide you on them. I think it's the other thing. I think there's one final question, isn't there? Actually, I've got one written down, but there's one in the chat box as well.
Have you got it there, Toby?
I've got it, yep. So if TESI is required, can DNA fragmentation be treated similarly to natural conception?
So when TESI is required, we're talking about using testicular sperm. Is that what the question is saying?
I think so, yeah.
Tested.
The question's a bit vague.
Can't be tested similarly to no. It's a bit of a confusing question, isn't it?
Bit of a confusing question.
If the question is, can you test sperm taken from the testicle in the same way for its DNA fragmentation, there are some fragmentation tests that can do that. In other words, can give you a result on very low numbers of sperm. Of course, you've got to be careful, because if you've gone so far as to do a testicular sperm extraction, you're not going to have very much sperm, and you may be a little bit, or the embryologist may be a little bit reluctant to use some of that precious sperm up to look at its fragmentation. But the technical answer to the question is that if you've got enough sperm from a testicular sperm extraction, enough sperm, then there are ways of looking at the fragmentation, though you may not want to.
Yeah. Yeah, I think the other part of that question is there any way that you can improve the sperm quality before a teaser type procedure? It's a very difficult one, though, isn't it?
It's very difficult. It all depends why you're having it.
Mm.
If you're having a micro-teasy because you have very, very few sperm, then I would always advise the patients to adopt the lifestyle issues. And if they have a significantly low testosterone, I might wish to correct that using one of the medications, not testosterone, to raise the output of testosterone on the basis that that just might tip the scales in favour of finding sperm in the man who has no sperm.
One final question, because I actually run over a little bit here. This was one came through Instagram yesterday. Will a varicocele embolization impact sperm DNA sort of fragmentation? Short term, I would guess, was the kind of question. So will that intervention have an impact on DNA frag? Should that man then wait 3-6 months for the sperm to recover?
Ideally, yes, is the answer. The first improvements will be evident at 3 months, but the best improvements are going to be 6 or even more months. So before we had ICSI for men with low sperm counts, and one of the only treatments we had was to operate on a varicocele, and you reviewed what happened to those patients. The pregnancies in relatively young partners, admittedly, occurred between 6 and 8 months after the varicocele treatment. So those were in the days when we didn't have the option of saying, oh, let's get on with it, let's do a cycle of ICSI 2 months after the varicocele treatment, 3 months, because there was no option but to wait for nature to take its course. So it's not just the one sperm cycle that is always held up as being the magic number, the 3 months, but in this case it's 2+ sperm cycles.
But it doesn't stop you waiting, though, does it, really? I think
No.
in the case of having had an embolization, I don't think people should wait until that next cycle, 6 months, 9 months
No.
later.
You can do the whole thing in parallel.
And it might just be a miracle that happens. So
But you mustn't expect it.
No.
Yeah, I think that's the message.
I think you're right. I think it's absolutely right. But yeah, it's an interesting one, and I think varicocele is very common in men, even probably underreported. So if you have the opportunity to go and get examined properly, I would probably recommend to do that and get that treated.
I entirely agree, Mike.
There we go.
It's a great shout for urologists. What a positive end.
It is.
Thank you very much, Michael. Close.
Yeah, I think we will close on that.
Oh, there we go.
And get,
There's
go and
another
get
pun.
tested.
Okay.
It's been fantastic tonight, Jonathan. Thank you so
Yeah.
much for your time. You've given up your trick or treating tonight to be with us, which is shows great commitment to the cause, I think.
I don't feel tricked. It's been a great treat.
Well, there we
and
go.
actually, genuinely, to speak with my friends about subjects that we're all passionate about. And once again, I thank all of you for leading on this.
It's great to have your
real
support.
Great pleasure, isn't it?
So yeah, everybody, thank you so much for tuning in. Thank you for those that are watching back. Do keep your eyes peeled. We've got some very exciting news. The testhim DNA fragmentation service, a whole new test for the UK, is coming very, very soon. We're just waiting for a few kind of administrative hurdles to be jumped over, but we're hoping to bring this service to the UK very, very soon. It will be available from people like Jonathan, and some other great clinicians and clinics. So do keep your eyes peeled for that. We've got more lives coming up this week. We've got Kieran Hannington tomorrow night talking about physical exercise and male fertility. Thursday night we're chatting to Gareth Landy about Klinefelter syndrome. And then actually following up and tying this week up really nicely, we've got Stephen Moser on Friday night talking about varicocele and how that impacts sperm quality. So some great content coming this week. Thank you all very much. Toby, well done. Thank you for being our quiz master from there in Deal.
Fantastic.
We're wishing you a speedy recovery. And a final thanks to our boys from Berkshire Media who are behind the scenes here.
Yes.
Have worked very, very hard to get this studio set up. They had to move it right at the last minute. So thank you, gents. And thank you all very much. We'll see you again soon.
Thank you, everyone.
Good. Thank you.
Good.